Hello, everyone, and welcome to today's OR Manager webinar titled How a Leading Academic Medical Center Increased OR Utilization and Access with Artificial Intelligence-Powered Block Management, presented by Cuventus. My name is Sharon Van Wicklen, and I'd like to welcome the attendees and thank our sponsor, Cuventus. Before we get started, I have just a few housekeeping comments. Today's session is being recorded and will be available on demand in the OR Manager store. We will take questions at the end of the discussion. We encourage you to submit your questions in the Q&A tab section on your screen. Your questions will only be viewable by the presenter, but not by other attendees. If you experience any technical difficulties, please use the chat feature and a webinar technician will come online to help you. I'd now like to introduce our speakers for today's webinar. Anthony Mormon is the Director of Solution Marketing at Cuventus and also co-led the design and development of the new Cuventus Perioperative Solution. Throughout his career, Anthony has focused on helping hospitals and health systems design growth, partnership, and competitive strategies. He has previously held healthcare advisory roles in organizations including the Chartist Group and GE Healthcare. David Adishru is the Managing Director of Perioperative Business at Cuventus, where he has led the design and development of the new Cuventus Perioperative Solution. Dr. Adishru has also developed other products and assumed clinical operation roles at the company. Dr. Adishru holds a doctorate in medicine from the University of Missouri at Columbia and received his plastic surgery training at the University of Kentucky. He completed his postdoctoral fellowship at Stanford University School of Medicine. In addition to his role at Cuventus, Dr. Adishru maintains a clinical practice at the University of California at San Francisco. Tammy Jones is the Chief Nursing Officer and Chief Perioperative Services Officer at the University of Arkansas for Medical Sciences. Tammy received her doctoral degree from the University of Arkansas for Medical Sciences. Dr. Jones has 27 years of healthcare experience in a variety of specialties and leadership capacities. In her current role at the only Level 1 Trauma Center and Academic Medical Center in the state of Arkansas, she has clinical, operational, and financial responsibility for 28 operating rooms, including the endoscopy lab, anesthesia evaluation center, procedural scheduling, system-wide sterile processing and high-level disinfection, and all other perioperative care areas. During her tenure as Chief Perioperative Services Officer, institutional goals for efficiency, utilization, and clinical and financial outcomes have been realized through harnessing automated, data-driven strategies and innovative approaches that drive performance of all members of the surgical team. Dr. Jones is committed to transparency of data and information sharing among all perioperative stakeholders and believes this is necessary to achieve full partnership and shared decision-making among surgeons, anesthesia providers, and every member of the perioperative team. She is passionate about ensuring the delivery of patient-centered care where this philosophy drives every decision made and action taken by the team. Cuventus has an exciting agenda lined up for you today. First, you will learn about each organization and the key challenges facing OR leaders in the market today. After this, you will hear about the issues that compelled Tammy and her University of Arkansas for Medical Services team to tackle these challenges with a new approach. Next, you'll be treated to a live demonstration of the Cuventus Perioperative Solution and a discussion of the impact that this new approach has had at UAMS and other organizations. The presentation will conclude with a question and answer session. And it is now my great pleasure to turn this program over to Tammy to begin today's presentation.
Thanks
Tammy?
so much, Sharon. Appreciate it. And I guess good morning or good afternoon, depends on where you are, and thanks for joining us today. I'm Tammy Jones. I'll tell you just a little bit about the University of Arkansas for Medical Sciences. We've been around for a while, since 1879. As Sharon mentioned, we're the only academic medical center and the only level 1 trauma center for Arkansas. We do provide care in all counties across the state, and our acute care footprint has 535 beds across 8 regional campuses, and we continue to grow that number. We're nationally and internationally recognized in a lot of areas, but for cancer and ENT, we definitely have a fair amount of notoriety there. We're proud of that. Our surgical program, again, 28 operating rooms, wide range of specialties, upwards of 20. We have invested heavily in robotics. We currently have 2, and we're adding a 3rd Da Vinci. We're the only facility in the state that has an ion robot. So we're really proud of this and looking forward to a lot of growth there. We did see nearly 120,000 outpatient visits last year, and we're really super excited about what the future holds for our facility and for our state, especially now that we've unlocked more capacity and some real good flexibility in our surgical enterprise.
Thanks, Tammy. I'll give some quick background and context on Qventus. We specialize in combining modern innovations such as AI, machine learning, and behavioral science with deep expertise in healthcare across clinical operations, performance improvement, and change management to simplify how healthcare operates. We're a proven partner, demonstrating success at more than 120 deployments across the country. So on the next slide here, I'm going to add some context on the technology before we dive into the perioperative solution specifically. I'll share a bit about how our platform enables sustainable results and rapid development of new solutions. First, I'll start with some quick context on machine learning. Machine learning, or ML algorithms, are a subset of artificial intelligence that are predictions based off of historical data that improve over time as more data and input becomes available. I can get one click here. The foundation of our system is a real-time automation platform that integrates with your EHR and enables you to manage operations as a closed-loop system. First, ML algorithms automatically predict and identify operational issues in real time as they're occurring, as well as in the future, predicting them before they occur. Next, actions are orchestrated using behavioral science-based techniques and process automation to complete tasks whenever possible. Finally, the system provides leaders with sophisticated statistical tools to manage accountability. That platform is the core of the system, and you'll see it really come through as we dig into the Periop solution. On top of that, we build, on top of the automation platform, we build best practice solutions. These are predefined bundles of software together with proven operational processes and management practices for key areas of healthcare delivery. Finally, we work with you to establish governance, drive change management, and operationalize these solutions. This is really important. We pride ourselves in being a strategic partner, not just a run-of-the-mill technology vendor. So as we develop new solutions, part of our early stage research and product development process is to gather thorough feedback from key stakeholders across the country. During that process, we uncovered really some key challenges that we felt were underserved and we were well suited to develop a solution for. We learned that OR leaders face a seemingly impossible task of improving access while simultaneously driving growth. OR leaders sit at the center of this challenge and really must constantly balance competing demands from both internal and external stakeholders. For instance, you've got an established surgeon who might not always use their full block time, and then they often release blocks at the last minute, which creates a scramble for the OR team as they try to fill that time.
One of the things I shared with Anthony and David during this process is that we also were faced with surgeons who would use our case request system in the EHR and then just think that, well, if they put the case request in, then that meant they had time, like it was magic. So we had to address that as well.
And just as a side note, Tammy's policy is actually in the handouts for the session today, so feel free to take a look at that later. Next, you've got rising star docs who are investing in growing their practices and they need more surgical time, but they may not have a block allocation yet. And you can be really challenged to give that to them if you're fully blocked out in your schedule. That limits your ability to align new docs. And then there's the internal pressure. So you've got your health system leadership putting pressure on the OR teams to not only grow the surgical business, but to outperform the market in key service lines such as orthopedics, cardiovascular, or robotic surgeries. And then all of that falls back on the OR teams who are constantly under pressure to respond to ad hoc requests, execute on these goals while dealing with the antiquated systems that make their jobs more challenging. So we heard all of this, and what we heard is that to make this system work, it requires consistent and constant heroic efforts from OR leaders and their teams to ensure that all of these stakeholders are meshing seamlessly.
And I validated what they'd heard with what we experienced at UAMS, where we have a small team that it sometimes struggles to meet the demand. And it results in a significant amount of a lot of back and forth manual work just to maintain the rigor of the policy and the results that everyone wants and expects. At UAMS, we had to contend with all the things that Anthony talked about and probably then some. We have a few unique challenges that further complicate our situation. We had a short auto release window. I say we have one, it's about 4 days, which puts a lot of pressure on the teams to fill release time. This window is actually extended from our pre-pandemic auto release window, which was 48 hours. There was no way for us to meet the demands of COVID testing requirements with a 48-hour release, so we took the opportunity to extend. The other piece to our puzzle, and maybe yours as well, is as the only academic medical center in the state, we have a significant number of highly complex cases, referrals, solid organ transplant, traumas, complex CV cases, and this generates a demand for inpatient surgical volume. So these patients aren't on a planned surgery schedule. They're often, as needed. So we have to block a room per day to account for providing that care, which adds further complexity when OR time is a scarce resource. So those are some of the things we experience, maybe you experience, but we also, as with many in the perioperative industry, are in the robotics realm, and fully utilizing our robotics capability was a challenge. We do have them dedicated into 2 rooms where they're stationary. We don't move them around, and we try to use those rooms as predominantly for robotics cases, but obviously there's more non-robotic cases in those rooms than we would prefer. So again, challenges that we have to contend with. So to begin to try to address all of that and more, we had to try to harness and all the current structures and tools that we had. So we invested in our EHR. We have Epic and other internal systems to maximize the automated reporting we could get and make sure it was reliable and valid. And all of the capabilities that these systems could offer us. So it gave us some improvement in reporting infrastructure and allowed us to provide more transparency to the surgeons. I actually was moved, it was requested in 2018 that I take over perioperative operations on an interim basis. We had a vacancy and a need. And I immediately dug in and began to look at where I thought I could help in the interim address some gaps. Well, when that turned into a request to make it permanent, I obviously said, okay, but we need some resources. So not only did I work with the chairs to say, if I'm going to do this, we're going to have to shore up policies and guidelines, but I also said to our executives and my boss, we need to look at our org structure. And in this case, I really focused on OR scheduling and the resources we needed to do this in the right way. Once we had the team in place and I had the buy-in of the chairs, we began to really work on the policies, the policy which you have access to. It's fairly robust now. It's well articulated. And maybe there's a few nuggets in it that you can apply and you will find useful. So to take it to the next level and continue to work towards our goals, we had to think even differently. You've got to keep pushing yourself, got to keep raising the bar. And we needed to look beyond our 4 walls because I knew we were only going to be able to go so far in continuing to improve efficiency and access and moving away from these manual time-consuming processes, which were very arduous. So we joined up with Cuventus and a group of other health systems in what is called the Innovation Cohort. I'm going to let David tell you a little bit more about the details of that.
Yeah, thanks, Tammy. So UAMS actually joined us as one of 3 partners as part of what we call an innovation cohort. And that's what that looks like for us is a first wave of clients to go live on a new solution. And we do this to ensure that the products we build actually cover a diverse range of partner needs and use cases that they might have. And when we pair this with the solution platform that Anthony actually showed you earlier, it helps to actually get our products in the market and out to helping patients even faster, which is what we care most about. And as we launched, what we did with UAMS was we set up recurring meetings to ensure that the solution was specifically customized and then trained in a way that was most effective for them. And then throughout the process, we wanted to make sure that the job for the schedulers and the OR leaders became more manageable. And then the health system leaders actually saw the progress that they were looking for against their strategic goals. So once planning and then configuration were complete, we then would invest heavily in the training piece and monitoring, with the idea of saying, how do we make sure we ensure that the solution was working as intended? And it's actually tracking towards the desired outcomes that each innovation cohort partner had outlined when we started the process.
David, I would just add that throughout this process from the institutional side, healthcare institutional side, Cuventus was amazingly responsive and supportive and a full partner in this. I would share that it's very apparent to me, though, that we approach this from a UAMS perioperative side of full engagement. I identified a team and really a leader in that team that we were all in, invested 100%. So we did our part. And sometimes that doesn't always happen. And it just really proved the saying, you really get out what you put in. So let's get into the fun part and take a look at how it all really works.
Thank you, Tammy. So I have an example outlining the status quo, and then I'm going to show you a bit about how our solution proposes to improve that. So in the status quo, what you've outlined here, you have a surgeon who may be 30 days out from the day of surgery, and they're not going to use their block time. They might be going to a conference or they have a kid's sports game, but they just didn't remember to notify the OR. Fast forward to 12 days out from the day of surgery, you have another surgeon, maybe an independent doc who's growing their practice, looking to add a really strategically important case for the health system. But when their office calls the OR to find time, they're told that they couldn't accommodate that request. So then the physician's office is forced to reach out and find alternative sites to find access for the patient. Fast forward to the day of auto release, which in this example is at 7 days, the block's opened up. And now the pressure's on the OR team to scramble and find any case they can to fill that time. After a few rounds of outreach, you might get a case or two, but all too often that time goes unfilled. So with the Cuventus solution, the access module will automatically engage with and offer incentives to the surgeon as soon as the machine learning model has high enough confidence that the block will not be used. In this example, that happens at 21 days out from the block, but can be as far out as a month. Once the surgeon's office clicks accept and releases that block time, the growth module, which is constantly monitoring all open time in the schedule, automatically offers that time to the best fit surgeon, which in this example would be the independent doc looking to add on a spinal procedure, such that when that physician is looking to add the case at 12 days out from surgery, they already have an offer in their inbox for that specific time. Once their office hits the button to add the case, all the steps in gray are eliminated that you see here, and you have a high value case performed on schedule with much less work for the OR to fill that time.
Okay, so let me start by giving just a broad overview and showing you the 3 modules that make up the product, and then David will take it further and dive into each one individually. So the first 2 modules are access and growth, and they're designed to work together in tandem with reinforcement from the 3rd module, the insights module. First, the access module uses artificial intelligence and machine learning to automate the process of unlocking as much open time as possible within your existing block framework. So the machine learning surfaces blocks that are unlikely to be used, and then it applies principles of behavioral science to incentivize the release, which is really a cool part. Next, the growth modules uses the machine learning to identify and offer time to the best fit surgeon. So in other words, who's most likely to be able to take and use this time. That really reduces the difficulty of the game of Tetris that OR schedules have to play on a daily basis. We all know what that looks like. Finally, actionable analytics not only put the most important metrics at your fingertips in real time, but it really gives you the data to enable you to have productive, actionable conversations with your surgeons. So let's dive deeper with David and look at the system in action.
Perfect. Yeah, thanks, Tammy. That was a great overview. I'll just spend a few minutes diving in here and showing you what this looks like. Feel free to drop questions in as you have them, and we'll do our best to answer them at the end. So when we approach the problem of access, we ask ourselves first, how do we enable an intelligent machine to actually help manage your block accelerating release times by an average of at least 7 days. That was our goal. And then thinking about what would that do for you? And the idea was, what would it mean if you didn't have to rely on your surgeons to remember to release, or not force your schedules to call with no data to support the ask or an incentive to offer in return to the surgeons? And then not to be in a position of going to a surgical governance committee without data easily available on the specific instances of productive operative minutes that were lost. And so the solution we built was a machine learning algorithm. It's actually tailored to the block time that's always on, and it's predicting when is the first moment for a particular surgeon or service line, if that's your way you're structured, that we could predict with confidence that a surgeon or service line may not need that time. And the reality is no surgeon wants to do this. So the key to getting this work isn't just the ML, it's how we use behavioral decision science to actually incent the action that we want. And here's an example. I'm going to switch over there for you. So in this case, what you're seeing is a nudge that we sent to Dr. Norris's office and his scheduler. They received this first prompt 17 days in advance of surgery because that was the first moment that the algorithm can be confident that the block he may not need. But notice how we don't just ask the scheduler to release the time. We give them the reason why. In this case, a prediction that there's only a 12% chance that they will need this time. And then we give them the direct benefit to them of taking the action in that moment, what we call a reward, which in this case is a 6% bump in their utilization. Then in a single click, the surgeon's office can take that action and communicate to the OR their intention to release the time. And then the OR can just jump in, right click, release the block, and close the loop back onto the grid. What we found at one of our partners is that we automated 89 of these release reminders a month, and releasing somewhere between 50 to 100 hours of block hours per month. And then because of that action of doing that earlier, and then the other parts of the module, we were able to drive up utilization to between 53 to 70% utilization of that time.
Yeah, and I would say here we had done a fair amount of work to shift the culture and made some progress in our surgeons really caring about their utilization rates and the subsequent possible consequences if they didn't utilize. But what this gives them is that real time. If you'll do this or seriously consider it, here's the benefit to you. So our engaged physicians really think this is cool.
So then the next part of the opportunity was this. Okay, so let's say you freed up that time. Next, we asked ourselves, how might we develop an algorithm to actually recruit strategic cases to fill gaps in your schedule with the goal of adding 1 to 2 cases per OR per month? And that's what we built here with available time outreach. And think about this. This is flipping the switch in the way we normally do things. This isn't waiting on a first come, first serve and just seeing passively if cases come. This is going out and getting the ones that you need. And so this is a machine learning algorithm, looks for any time there is an open block or a late release or a late cancellation, and predicts who are the surgeons that actually are the best fit for that time against our prediction of their availability and your specification of strategic goals. And then one by one, it's reaching out to the next best matched surgeon until it fills the slot. Let me show you what that looks like really quickly. So let's say at the start of my clinic, so actually, sorry, this is the kind of example here. And so we solve for this by, I'm actually going to pull back here. Yeah. And so here's what you're seeing here. And as soon as this robotic slot becomes available on 11/25, which you see up there, that's 4 weeks out. The algorithm is strategically prioritizing outreach to Dr. Hamilton's scheduler and saying, look what it's saying here. It's saying that, look, we've got time available. Would you like to use it? And if that happens to, if he happens to need that time, he can actually click and let the office know, I'll use that time. And then it's coordinated with them to let them know that he needs that time. And as the surgeons interacted with this product, it got better and better. And that's one of the things that's actually really key about machine learning, which you'll see here. As they interact with the product and use the buttons below and indicate that they need time or they don't need a time, the algorithm's actually learning and evolving with them to figure out when is the next best time I can market a time to them. But more than even the new volume, it's how it makes the surgeons and their offices feel, especially for some of those earlier career surgeons who don't have block time or surgeons that you're trying to recruit. It makes them feel like the OR is really trying and working hard to make time for them.
One of the things that I shared with Anthony and David is that I can also see where there's this cycle to this. So if they're incentivized to really consider releasing their block, because then They know that if others will do that, then that perpetuates the marketed time as well as the availability of time in Time Finder. So there is kind of this greater good and how it comes back to each of them in potential time when they need it.
Yeah, and that's a good segue. So as Tammy mentioned, HEO was the first part of the growth module, which is the push based. But the second part was the pull based, and I'll kind of show you what that looks like. So as we also thought about this, we asked ourselves, how might we enable surgeons' offices to find the exact time that was available across your system without ever having to pick up the phone? And what if they could actually see their colleagues' times that maybe they won't release to you, but they might be able to let a colleague use? So we solved for that by building a product that we call Time Finder. And this is the one that's a reservation-like interface to streamline access outside of the EHR. So any surgeon and scheduler can view and request slots down to the hour level. I think this is beautifully designed. So I'll actually take a moment here to show you how quick and easy it can be to use. So let me pause here. Okay, cool. So let's say at the start of my clinic, I have a patient that comes in and they're asking for a robotic surgery. So I'm Dr. Norris, and I've got a patient that says, look, I'd love to get a case on for robotic sigmoid colectomy in the next month. What I know is that my block time is fully booked. And so I'd love to see what time is available outside of that right now. And what you notice, which we're not kind of immediately obvious as that pulls up, we do a prediction of the actual wheels in to wheels out. So as you're pulling up the case, you're actually getting a true sense of what the OR is going to consider that case length is going to be. And what you see arrayed back here is a set of times. On the right-hand side, what you see in green is the available block time for the surgeons. What you see in blue are the open times actually across the different places in the operating room. And then down below, you'll see in orange and then in gray, you'll see colleague times, both in your service and out of your service. And again, that's the one where this is our prediction of colleague has time that they haven't released in their block, but we predict that they may not need. And so what's not immediately obvious is that the times aren't arranged chronologically. They're actually arrayed predictively. So we're putting the ones that we actually think are the best fit or most strategic to fill up top, again, using those principles of behavioral science. And then also just keep in mind, you're showing the different locations. There's multiple different locations that are shown here that you operate in, as well as days of the week and the room types that you can filter across. So let's say you're looking for an available time and your scheduler says, you know what, block time's filled up. I can't get this in earlier, but you know, this would be great. I can actually make this Wednesday time work and this Friday time work for my surgeon. And so they can click next step, go to a checkout screen, and they may say, you know what, Wednesday could work, but Friday's actually probably better. What I love about this is in one go, you're able to communicate what your true preferences and flexibility are to the OR. And you could say, well, Dr. Chastro actually has clinic here on Fridays. He needs to be done in the afternoon, so let's shorten that time frame. And then I think on Wednesday, I'm able to start just a little bit later in the day. So adjust that. And then you can add any notes to the OR that you may need. Now, something that is also available for groups of you that have independent schedulers, we actually built out an electronic procedure order form with the idea being, let's just catch all that you need in one go. So since you're saying to your independent groups for your scheduling in block or out of block, I want to enable you to do this without any more faxes, no more phone calls. Let me just get all the information you need, and that's important for us to schedule and reduce that burden on those teams so that they can book into the time. And then they're able to submit that time here. And then let me show you what that ends up looking like. So when they click submit, what they receive back in the OR side is this, a notification letting them know, for instance, that in this case, Dr. Norris was looking for that robotic sigmoid colectomy. It's 240 minutes. Here are my preferences of time. They can see a procedure order form that it gives them all that information that they had been looking at before. And then they're able to evaluate the time. If it's available to be added, say, let them know that the case will be added. And then again, a closed loop system, an automated message goes back to the surgeon's office, letting them know the time was able to be honored.
And, you know, for places like us that really struggle with capacity, what Time Finder really offers surgeons and their scheduling teams in the clinics is, you know, a sense of control, and it helps with that feeling of not knowing, uncertainty, and really helplessness. They can themselves go out, use the system to look for time, and they're feeling like they're being proactive and not dependent on someone in an office somewhere that they're talking with over the phone.
Yeah. That's a great point, Tammy. And I think that's the other thing that you've got to understand, and I think I understand as well from my own office, like my scheduler has limited time and capacity. And so I've got to do things to make it easier on them to get me into the operating room. And also like the other like painful reality is sometimes you get a great scheduler. Sometimes you don't when you start out, have a scheduler that's maybe perfect at really being proactive and going out and finding you the best time. So I need to make it as simple as possible for them to help them help me. So then we asked ourselves, how do we put the real-time transparent data at our leaders' fingertips so they can manage accountability and have productive conversations? And this was what we built here within the Insights module. Because the OR resource, it is just too precious. And because what we know is both you as leaders and surgeons need data, but we're all incredibly busy and we don't have time to do that. So I think we came at it from a foundational understanding that it's unacceptable that you should have to wait for a historical poll or transform not quite right reports out of your EMR, or even hunt and figure out what's important to look at. So we curated those insights and delivered them in real time directly to surgeons and periop leaders, so they can both identify improvement opportunities and have a basis for data-driven conversations. And that's what you're going to see here in Opportunity Finder and SPI. I'll give you a quick look at what that looks like. Here's an example of what Opportunity looks like. Opportunity Finder looks like. Again, imagine that these are metrics are curated for you. They're available in real time, refreshed on demand when you want them, and they're showing things in some interesting and nuanced ways that I don't think have often been done before. Interesting things like looking at case scheduling accuracy, so you can figure out, well, who are my services that are really more often than not outside of the accuracy that I would hope, but being able to just dig down in one go and see, oh yeah, so ENT, why is it that 35% of them are scheduled outside of what I would expect? And maybe you can drill in and see it has to do with a specific case. And then looking at things specific to robotics, which we don't have time to talk about today, but we can dive to in more detail. And then something also for the surgeons. So for the surgeons, being able to have a system where the metrics that matter to them are delivered directly to them. They're refreshed in real time, allowing them to see things like their backlog and their scheduling lead time, being able to stratify their case scheduling accuracy and how they've done over time, being able to specifically look at a breakdown of their cases and how they are doing against their scheduled duration versus other surgeons or colleagues within their system, and getting a look of their efficiency metrics, not only just looking at them, but comparing them against averages for the rest of your departments in the operating room. And I know, Tammy, this is something that you've used quite a bit, so I'll let you talk a little bit more about it.
Yeah, I mean, SPI is very similar to what we were attempting to do before working with Cubentus. And as David mentioned, he said it's unacceptable that you should have to wait for historical pull or transform not quite reports or hunt to figure. That's exactly what we were doing. And I was pretty proud of what we had put together, but this takes it to a whole new level. And you talk about cultural reinforcement. Yes, it provides the surgeon their specific real-time picture of their practice and helps them understand the impact of their actions. And it either tells them a good story that they can be proud of, or one that makes them maybe rethink. This is something I talked to Dave and Anthony about. Obviously I have access as a perioperative executive, but we also want the chairs and service line directors to have access. Again, giving a real-time story that is transparent, we have some predictability, and can really shape our culture in the positive way. Yeah. And I think the only other thing I'd add there that I think makes a ton of sense is when people often start at this, I think people have intuitively said, it'd be nice if we can just like select a set of metrics and then look at them. And sure, we do that. But the other thing is like, I don't want to do that, honestly. I want you to curate the story for me so that I don't have to pull up one metric and then pull up another and figure out what should I look at next. I want you to curate the story so I can look at it and make a decision, because honestly, like, we don't have time for that. I'm not sitting around waiting to see. I've got hours of my day to do this. I need to be able to look at it something quickly and pull an insight out of it to use. So what I'd like to do is take a look just for a few minutes at some of the impact we've had with the solution so far. Okay, I'll talk a little bit about that specific to UAMS and our partnership. We've been extremely happy with not only the process of implementing the solution, but the results we're realizing so far, even during a pandemic surge. there really is significant benefit to all stakeholders for this automated system, not just the schedulers in the clinics, but the surgeons as well. And, obviously your bottom line. There's transparency, self-service. Stakeholders no longer have to pick up the phone. We've talked about that, and make a call. That's a huge satisfier. It really unlocks time for everyone, but especially my schedulers. Another aspect of this is the scheduling lead time, and cases added through the solution have really helped us grow and help more patients, which is the ultimate goal and the focus here. So you can see during this time frame where we've added 216 cases, you can also see while it's early, as we annualize the impact that we're seeing so far, we're over upwards of 952,000. So excited about that for sure. And then we get to the surgeon practice insights, which clearly you can tell, I think this is really slick and I love it. And we're anticipating there will be significant impact here as we really empower our surgeons with this real-time peer benchmark performance data. And I don't know about your surgeons, but that speaks to mine. And it's what they want to see. And to David's point, it's in a package. They don't have to go to 10 different places. I don't have to go to 10 different places and pull it all together. It's there, painting the picture. And while we'd improved on some of this, again, before Cuventus, we've taken it to a whole new level. And what we expect as we have serious growth and expansion plans is having a system like this is going to help us achieve more flexibility, better inform the decisions we make, because we are going to be opening a surgical hospital in March of 2023. So we need to be positioned for that. And we feel really good about how this relationship and using this product helps with that. Beyond the hard return on investment, which we're all, focused on, and it's very important, there are really important benefits that are just as meaningful. And I've already said satisfaction is a huge one, what it does to reinforce the culture that you want, and patient outcomes. Obviously, the more patients we can provide care for, the better. That's what we're here to do. To help illustrate that, we did send out kind of a survey, pulse check on what our users were thinking about the system. You can see some quotes there. I think probably my favorite is the last one from a plastic surgeon who I'll tell you doesn't have a lot of block time and is pretty busy. And it was tongue in cheek, but he was serious because he's talked to me about the system. And he says in his response to the survey, quote, "I've been getting into the OR a lot, ! Don't tell other people about this. That way I can keep getting OR time." So that was really good to see, really positive feedback there.
Yeah. How honest and true to great. So I would definitely say that the most rewarding part of our work has been the impact that we've been able to have with partners like UAMS. Together, we've been able to achieve significant, and I would say sustained results that really feel meaningful and augment the business. Our partners are able to add 1 to 2 cases per OR per month, and that can translate to 20 to 70 cases per month in total for each of the health system partners we work with. Conservatively, we know that drives an incremental about 100,000 in contribution margin monthly. That's over $1 million annually. And that feels meaningful to a system where margin is important because it actually enables the mission. So many of us have worked across the inpatient side, the outpatient side. We know that the work that we do for our communities is dependent upon being able to have the margin to be able to do the services and offer those things to our community. And so with an ROI of more than 4 to 1 and a break even in a quarter of a launch, the really important thing is that feels doable, even for an IT strapped and incredibly busy org, which UAMS and all of our partners are in the midst of. They were in the midst of post-COVID or in the midst of COVID when we were actually able to launch this. And on top of that, we find that increasing lead time for block release by about a week and then driving utilization of that release time to over 50%. That's almost double of some of the best quoted industry standards.
Yeah, for sure. So I'll kind of just give some closing thoughts and maybe wrap this up a little bit. If you find yourself in a similar position as mine, where the institution that you work for expects you to come up with strategies and utilize your OR time, we all know that's important to healthcare institutions for so many reasons. The place that you really need to start is doing an internal kind of high level gap assessment to think about and estimate the impact this type of tool and structure could have on your organization. As you look at your gaps, ask yourself questions like, how are you tracking and running your ORs, including current utilization, current release time, whether it's at the service level or surgeon level. That's going to be dictated by how you run your blocks. And think about how blocked out you are and what you're currently doing to enable your services to recruit new surgeons. This is a big deal. It's hard to recruit a surgeon when that chair can't articulate for them their OR time. Based on the gaps you identify, the initial benefit of certain parts of this solution are going to rise to the top as important. For example, the SPI module can deliver huge improvements if you don't have a current reporting platform. If you have no way to paint the story at the surgeon level, it's an uphill battle to shift your culture. If you're completely blocked out or largely blocked out, so for us, we only have a couple of rooms of open scheduling. So Time Finder and available time outreach could significantly improve your ability to meet the needs of your current surgical staff, but also how you speak to the recruitment of new surgeons. So really asking yourself these hard questions, doing that analysis of yourself, and understanding this can help sharpen the case that you will make as an executive for artificial intelligence at your organization and how you unlock the ability to use it to your advantage while increasing your ability to serve more patients. So, I mean, that would, I guess, just be my advice if you want to take this to the next level in your institution. And I think as far as our presentation is concerned, that sums it up. And we will kick it back to Sharon.
Hey, y'all, that was just a great presentation. Thank you so much for your participation today and sharing your insight. And yeah, we'll open it up for questions and answers. I want to remind everyone to submit your questions in the Q&A tab section on your screen. And your questions are only visible to the presenters. So the first question that we have is, what does the implementation process look like, and how soon could this be up and running?
I'll take that one, Sharon. So typically for a 20 to 30 OR site deployment, we'll have the solution up and running within about 8 to 12 weeks. So that depends on some site nuances and whatever the goals are of your organization specifically. We start that by really sitting down with you and understanding strategically what would you like to achieve and what are your major pain points and challenges that you're looking to solve through this partnership and the deployment of this solution. So then in parallel, then our tech team gets to work setting up the EHR integration that'll be necessary to train the models, pulling in the few years of historical data that we can build from, and then setting up the data pipeline. And it does work with not just Epic. I know we've mentioned Epic quite a few times here because that's what UAMS is on, but other EHRs as well. And then after that planning and configuration, we start training users. So we work hand in hand with them, supporting them as they prepare to go live, as we lead up to the launch of the solution. And then we enter a phase called hypercare. So when the solution's first live, we're really hands-on there with you in the trenches, so to speak, making sure that this is a success and integrating any feedback we get from the frontline users to ensure a smooth adoption and rollout of the solution. And so far, that's been great. Good feedback from folks. Anything to add, Tammy?
It's so important, that support.
Absolutely.
Yeah,
I would just concur and say that's exactly how it works, how we experienced it. They've got it down pat.
Great. Can you share any other lessons that you learned or any critical success factors from your current partners?
Yeah, that's a good question, Sharon. I'll take that one. So I would say this effort actually really requires a true partnership. Client partners have to invest the right resources, but at Qventus, we really have to understand the client's goals and nuances of their solution as well and what they're looking for. We have to be there with our clients the entire way until the solution is adopted and then up and running. And that starts with an investment up front in us and understanding the strategic goals of you and the partners that we work with, and then challenges facing our client partners right now. And then we need to pull up our sleeves and roll up and be elbow to elbow, where we're supporting them as they invest in marshaling the resources they need and making the training and process change a success. And that's what Qventus is doing. And I think for us, that is we felt like really key is being that close of a partner to the orgs that we work with.
Awesome. What are y'all excited about moving forward?
I'll speak to that. I tell you, for me and for you, AMS, there's so many features on the horizon and so much yet to be realized from this partnership and these strategies that we're so excited about. We've had so many distractions with the pandemic that we're really just ready to have a clean run at this and fully realize all of the benefits that we know they're going to be. And I think it's important to keep that in context. When you see what we've been able to achieve thus far, you know, Arkansas has had a really rough time with the pandemic. We're still hopefully coming on the downside of the surge, but we had a really tough surge December, January, February. You know, we bounced back for a little while, and then mid-July it hit again, and this affected our ability to liberally schedule in the OR. But all through that, and to go back to what David's answer, they were with us. I mean, we meet weekly. And, you know, when we needed to scale back and when I had to contract down on what we could schedule, I said to the guys, look, we may need to turn off the marketing time for a while because I'm having to watch things so closely. But that's the kind of partner they've been. They've really been in the thick of it with us. So we're just ready to be unencumbered and to just rock this thing. And I'm completely confident that's what we're going to do. We just got to move a little bit further past the pandemic.
Yeah.
Awesome. Does the product use historicals?
Oh, yes, I hit on that a little bit in mine. Ideally, we'd like 3 years of historical data to train the models. And then as the users use the models, it'll learn from their interaction. So if you accept a nudge or decline a nudge or give some feedback, the machine learning picks that up and improves itself over time. And I think David might have had a few things he was excited about. Sorry.
Yeah. No,
sorry, Dave.
No, it's not a problem at all. I did want to share a couple of things I'm excited about because I think they're coming down the pike. And I think there's 3 things I would say. I think one is the robotics transformation and access. Look, robotics is a conflict everywhere. Each of the partners that we work with, there's a perceived conflict amongst the surgeon for what is a very expensive resource. But when you dig into the data, it's because there's like process and things that are actually happening that aren't allowing you to actually maximally leverage that like very expensive resource. And so I think working on the robotics transformation along with our partners is something we're super excited about. I will say every single partner that we have talked to has been asking about endo, cath, and GI and expansion to those areas. We see that as a nice corollary to what we do now. A little bit of additional design work being needed there, but it's where we want to head, and we think there's a way to service those areas. And then surgeon delighters. One of the things that we have in process right now is the ability to develop a system where we can help surgeons grow their practice in the direction that they want. So this is something that's very different. So this is about looking into the market and saying, how do we help drive strategic referral volume to the surgeons that they most care about? So instead of doing 10 of 50 procedures, they can do 50 of 10 procedures. And we know what that means in terms of surgeon experience and then patient experience and then quality of outcomes. And so that's something that's really important to us. And then also, same thing, using that market level insights to be able to do things like drive strategic service line growth. How do you find the right clinicians within the market that you think have the volume to be able to grow the practice in the way that you want? Or how do you figure out where are the local zip codes where you can dig in and identify and open up an opportunity by creating a referral pattern to a facility that you have in that market? And then I think lastly, with that, site of care optimization. So looking in and saying, you're investing in an ASC, you want to do the right procedures at an ASC versus your outpatient ORs. And how do you do that? How do you actually set up to do that and understand what are other people in the market doing? And then how do you actually drive the volume there automatically using a machine learning algorithm? So those are some things that I'm pretty excited about.
Awesome. It sounds like you're excited, and that's great. So this question I think you addressed, but I think it probably bears repeating, is how does the system know that the block won't be used?
Yeah, I think so. This is something that we'd be more than happy to talk about in depth. So we have a whole team that is heavy into data science and machine learning. Our CTO has a PhD in machine learning from Stanford. And the way that this works is, I think Anthony mentioned before, we use ideally 3 years of historical data, but we only need as much of 6 months. And really the way that this works is it's taking a historical data set and building a model that's able to predict. And then what you do is then you take a different data set, a period of time, and you train it against that data. And you see how well did you do by using that historical data to predict against a training data set. And then you keep doing that. And that's the thing that also becomes important in our model. As you can see, we're marketing all these times out to the surgeons. And if they don't respond, we learn from that. If they say, yes, I'll use the time, we learn from that. If they decline to use that time, we learn from that. We actually reach out to them from block release. And if they say, yes, they'll release the time, we learn from that. And so the model's constantly updating because practice patterns change. I may be available on Tuesdays, and then next quarter I have a clinic on Tuesdays. I may be using my block because COVID hit and it really impacted me, but then a few quarters later, I may be using it all the time. You can't have a static pattern of looking at this. Regression is not going to get you where you want to get. So you want to actually use a model that evolves over time.
That is just awesome. Is there a way to send that response to certain physicians to pick up the time, or is it already preset to send out to all of the surgeons looking for time?
Oh, so that's a great question. Let me just clarify that. So it doesn't go to all the surgeons, because you know what I don't want as a surgeon? I don't want to be spammed. And you only have so much brainwave for a surgeon's office. So the way that it's set up, it scores every surgeon against that time. That's what the model's doing. And then it says, let me go to the top rank 1 first. And I'm going to give them a short window to use that time and create scarcity in their mind that either I got to use this time or pass on it. And then if they say no, or they don't respond, it goes to the number 2 and reaches out to them. So it goes one by one individually, trying to get the time filled by the most strategic next best map surgeon.
And I think what's unique and kind of one of the things that we really wanted to build into this is that we could just easily say who's most likely to use this time and base a prediction on that and offer it to whoever's most likely to add any case. But we think the key to this being really of strategic value to a health system is by building in their strategic goals. So if you really want to grow orthopedics, we can improve the prioritization in the fit score of the orthopedic surgeons and offer the time to them with a higher confidence in the match scoring.
And I would just add another element to that. You know, in a time like we are where things are constrained, I could have told the guys, let's do some resetting and let's put our cancer services as priority for marketed time. Because I know I'm getting a backlog of oncology cases that have time sensitive need. So there's so much capability.
I imagine this also gives you data to respond when surgeons maybe give you some pushback. You have the documented data that the system provides. That's really great. What is the level of integration with your electronic medical records, such as Epic? I know you talked about Epic a bit.
Yeah, and I can speak a little bit about that, and then David, feel free to add in. But basically, we have 3 to 4 different tables within Epic that we pull from. We don't have to set up an HL7 full real-time feed to drive this solution. Typically, 15-minute updates for the most important information, such as cases and block allocation, is sufficient. But that's typically what we set up, and it's refreshes anywhere from daily to 15 minutes, depending on what type of information we're going to be pulling into the solution. And that is all set up within about the first 6 to 8 weeks of the partnership as we're getting things running.
Yeah, I think the only other thing that I'd mention there is, as the way that we built our solution was, as you see in Time Finder, it's down to the hour. I think for us, we recognize in order to build confidence from the surgeons that we work with, and also just to meet their workflow, we need to be able to give them what's actually available. I'm not available like just willy-nilly at any time during a day. I've got rounds, I've got clinics, and there's a specific time interval. And so for us, we actually did a direct integration with sticky notes also in Epic and other EMRs. What that does is your scheduling team is using those notes to do things like close rooms, temporarily close a block, say that you've got training during a day. I can parse those automatically and understand, is that it truly available or not available? Did you move someone's block from one room to another? Those are the types of things that you need to do for 2 things. 1, to be able to actually show the availability to the surgeons so they can book their cases. And 2, so you can go back and do the analytics to actually know what was things like utilization. So that ability was something that we had to build over time. And I remember when we first did that, we reached out to Epic, we reached out to the community. No one had ever done that before. That's something we pioneered in the ability to do.
Mhm. Are you able to program in parameters such as availability for pre-anesthesia screening into the prediction of what time works best for certain surgery?
Yeah, so it's a good question. With pre-anesthesia screening, that's a specific nuance that we actually haven't done before, but I like the idea. The bottom line is, think about it this way: as long as we can get a feed for that, meaning that we can pull that into our database and understand how to use it, then absolutely we can use it. And I think kind of going along that line of questioning, if we know when their pre-anesthesia screening is scheduled and therefore then when they might be then available for surgery, then yes, that can become a factor in thinking about when we reach out to someone about a potential ability to add on a case. I'll give you another example. One of the things that we're doing, and I just thought of this as far as the flexibility of the platform. One of the other things that we're doing at one of our partners is during this time of COVID and trying to understand how do we build more intelligence even into knowing who to reach out to for an available time, even beyond pre-anesthesia screening. We're doing things like looking at their existing cases in the future, running an algorithm against their future cases and saying, which of these might we be able to pull forward? I'm a surgeon who has scheduled cases electively, and I'm looking out 8 weeks out. Now there's no ability for me to do my admit cases, but maybe what I can do is pull forward my outpatient cases, do them now, create downstream capacity to do my admit cases when I can actually get back to doing them. So it's an example of how, again, you can use that algorithm in a custom way.
So when you're using the feature that allows the office scheduler to look for time and to input all of the information without a call, how is that communicated with the hospital schedulers? Is there a queue that it goes into?
Yeah, so it's a great question. So there's two ways that it happens. The first one, as soon as they hit submit, it actually generates an email to the office schedulers that often use a shared inbox so that they can see that message come in, and they prioritize working through that queue in the inbox to get those filled. The other way is we also have and I didn't show this at the time, but there's what we call an activity center that's available for the OR schedulers. So the OR schedulers can go in and see a queued list of the requests that come in and be able to tackle those as they come in.
Okay, I think this is going to have to be our final question, and we're running low on time. Can you tell us how is this product different than a similar software such as LeanTOS or IQ?
Anthony, do you want to take that, or do you want me to?
Yeah, I can get started on that, and then maybe you can join in here. And I'd say there definitely are some similarities. I mean, both organizations are focused on the goal of creating surgical access and reducing the barriers that there are to getting patients the care that they need in the OR. And they really kind of blazed the trail and proved that there was a market for this kind of intelligence and automation in the OR. And so in that respect, we both share a similar goal of transforming the OR, making it more efficient and helping reduce barriers for patient access. Where I think we have some different approaches is around just our infusion of behavioral science to ensure that the nudges are very carefully curated and surface at the exact right time. Because dealing, with surgeons and all the other challenging stakeholders in the OR, people don't have a lot of time. They really just need the correct information at their fingertips at the right time. And incentivizing and helping them think about it in a way to take the action that'll be most beneficial for everyone. And so I'd say that's probably the first big piece, is where we really prioritize behavioral science and the user design and interface of the tool. Secondly, I'd say machine learning. That's just where we have a ton of experience there, and operationalizing machine learning algorithms is kind of our core business. It's pretty easy to make a machine learning algorithm. It's much more difficult to stand that up and ensure that it's sustainable and sees consistent performant results over time. And that's something that we have a lot of experience in, that we've built into the core of this product.
Yeah.
So those are two big ones. David, I'll let you take it away with what else.
Yeah, to build on what Anthony said last time, I think some of you might be aware, like as a case in point of that, we built the world's best predictive model for COVID growth during the COVID pandemic. It was 10 times more accurate than the IHME model. It was used by the White House and hundreds of hospitals across the country to align resources. That's just an example of like the premierness of like the actual machine learning that was built in the company. I think the other thing though, specifically to like what we do differently, and like Anthony said, like I think LeanDust has built a fantastic product and they've done great things with their partners. So would never say anything negative about them. I'm really encouraged by what they've done. But I think we did things a little bit differently. And I think some of the things that we did differently is that focus on the marketing automation and what you can do with that platform of being able to push things out in a strategic way. That was pretty unique to us. And then when you think about Time Finder, the way that we looked at it down to the hour level of booking and how we created that interface, some of the feedback we've received from people in the community is that looks pretty slick. And it's actually really nicely designed and does things a little bit differently than we'd seen other people do before. And then the last thing I would say is the component of our platform specifically around driving market demand and strategic referrals, that part that we're developing is something that I think is really interesting and exciting to surgeons because that's one of the things that they care most about is figuring out how do they get the strategic referrals they want and thinking about how do we grow strategic service lines in a way that we give insights into that client that they haven't seen before. And so I'd say those are the things that generally I've heard seem a little bit most different.
And with that, I'm going to say great big thank you to all of our speakers and to Qventus for hosting this webinar. We're nearing, we are at the end of the hour, and so we are going to be signing off. I just want to remind y'all that the handouts, including a copy of the slides and the policy that Tammy Jones has developed, is available for you. The webinar has been recorded, and you will earn one continuing education unit for completing the quiz. That will be available in your OR Manager account. And that concludes today's webinar. Thank you once again to all of our attendees and to our sponsor, Qventus.
Thank you.
Thank you, everyone.
Thanks, everyone. Nice seeing you.